Welcome to Your Doctor Wants to Quit, a podcast inspired by the need to save healthcare in America. I am Dr. Joy, a board-certified emergency physician, and I created this podcast to shed light on the challenges our healthcare system is facing through the multiple lenses of doctors, other healthcare professionals, and patients. By listening and working together, I believe we can fix healthcare in America for all of us.
If you're looking at precision medicine, it is a completely different perspective and approach than the population-based medicine approach we're taking today. And population-based medicine served the country relatively well, but it's not serving the individual patients very well.
You are hearing the voice of Dr. Joe Weiss, a board-certified gastroenterologist, otherwise known as GI Joe. His wife is Dr. Nancy Cetel, reproductive endocrinologist and author of the book Double Menopause. For more than 30 years, these two doctors have shared their love of medicine and their love for each other. In today's podcast, I am on a quest to find out why, despite all the frustrations in healthcare, over the last 3 decades, they never quit.
This is Dr. Joseph Weiss. I am a gastroenterologist, which is a specialist in digestive diseases and disorders. My background, I grew up in Detroit, Michigan, which I mispronounced on purpose. It sounds much more elegant. And yes, I do shop at Target and I take out the garbage. So coming from Detroit, the Motor City, it was an interesting place to grow up. But for the last 40 years or so, I've been in California. Happy to make the transition. For a gastroenterologist, you have to complete the residency in internal medicine first. So I spent 3 years of training in internal medicine. And that's actually where I met Nancy. We were both up at University of California, Irvine, which is up in Orange County. And we met in an elevator, but I'll spare you the details of that story.
Hi, I'm Dr. Nancy Cetel. I am a reproductive endocrinologist, which is a subspecialty of OBGYN. I've been in practice for 30 years or so.
We are a couple, although we do have different last names. I've been in practice for about close to 40 years. I'm on the clinical faculty, a volunteer at the University of California, San Diego, a clinical professor of medicine. I love learning. I love teaching. I'm curious about everything. I've really enjoyed taking care of patients. I've learned so much from them over the years. And both Nancy and I are really passionate about patient care and about being advocates for people navigating what we see today as a very dysfunctional American healthcare system.
Right now, my main focus not only is women's health, but also being a special advocate for patients' health. So I am spreading the word, especially in the women's health arena of perimenopause and menopause, where unfortunately there's been a lack of information and perhaps some disinformation. So I'd like to educate the public, and I'm very devoted to that cause.
One of my favorite quotes is from Walter Cronkite. I may be dating myself. He was a famous broadcaster on CBS with the evening news. What Walter Cronkite said is the American healthcare system is neither healthy, caring, or a system. Now, take that as criticism. So we're happy to discuss our frustrations and our vision for what healthcare should be, but we are really advocating patients to be self-advocates, first and foremost, to ask questions and make sure that you're getting the healthcare that you deserve and you need.
Between Dr. Nancy Cetel and Dr. Joe Weiss, this delightful doctor couple has over 70 years of experience in the medical field combined. Their perspectives on how medicine has evolved over the past 40 years is invaluable, and what makes them uniquely special is they are both committed to patient advocacy and striving for a personalized approach to healthcare. But before getting into more serious topics, I just had to find out how the magic between the two of them began. So I know you said you were going to spare us that elevator story of how the two of you met, but I was wondering if perhaps Dr. Nancy might be willing to share.
Oh, that brings us back to the early days where we were both doing our internship at University of California, Irvine, which is in Irvine, California. I was a very brand new intern, and part of the OBGYN internship includes rotations through internal medicine and surgery and pediatrics and a variety of the other subspecialties. But this was about my first day, quote, on the job, brand new, fresh out of medical school. And my first assignment was to work in the intensive care unit, which was very frightening. And I was assigned about 15 patients, and they were all very ill. And so I had a notebook with me, each patient's name, what their diagnosis was, and what the problems and what their medications were. It's kind of like being in the Army. So there's a hierarchy, and being an intern, you are at the very lowest end of the hierarchy. So I was taking care of these patients and at the same time wanting to get some guidance from my sergeant, so to speak. The sergeant would be the resident. So looking all around, he was nowhere to be found in the ICU unit. And by the way, we are all wearing the uniform. It's not an Army uniform, but it is the blue scrub suit uniform. So we kind of all look very similar, especially, blue top, blue bottoms, and we're all running around like little ants. So I came upon a tiny little break in time, and I was getting into a crowded elevator. I was in the back in my blue scrubs, desperately hoping to find my superior resident so I could run off all the issues and questions I had. And people were pouring in each layer elevator would stop on, and I said, "Oh my God, good! I think my resident's coming in." And I just saw, the blue scrub suit from the back, and it's a tall guy. And so I'm squished in the back, and I tap the resident who's standing in front of me, but with his back to me. So I give him a tap on the shoulder, and then I immediately turn my attention to my notepad and start rattling off, "This is so-and-so in bed A, her blood pressure is going up, and do I change the medication? Mr. So-and-so in bed B, his glucose is high, what do we do now? And so-and-so." By the time I get to number 5 on my list, I finally look up to see who I tapped on the shoulder, and looking back at me with a smirk on his face is, here we go, Dr. G.I. Joe, who is not my resident. And so he's looking back smiling, and I am so perturbed because he definitely was not my resident, and I just wasted all that time. So I look at him and just shout out, "Oh my God, you're not the one," because of my frustration. And he had a really cute little comeback. I'll let you say your comeback.
Oh, but I could be.
Or no.
But I might be.
Why can't I be?
Oh, I don't know what it was I said, but something that got your attention that ended up we had to wait, I think, a month before we had our first late night date because there's no time. I was a resident, I was a year ahead of Nancy, so we ended up having our first date a late night snack. And of course, I thought that was a dinner. I ate everything on the plate, and Nancy said we were sharing. I found out afterwards I made a faux pas as far as our first date.
So anyway, we did meet by accident on an elevator. I'll say the good thing it was going up, even though my not very sweet comment was, "You're not the one."
Oh, that's an adorable story. Thank you so much for sharing that. And I think it really takes us back in time. So if you could maybe just share with us what year that was. And also, I'd be curious to hear what your mindsets were at that time when you were just at the very beginning of your postgraduate medical training, just to kind of, give us a picture of what was going through your head, how you were feeling about your career and the direction of medicine at that time.
So it was the late 70s and very excited, anticipating a future career as a physician, taking care of patients. The whole world was ahead of us. And at that point, I think our medical system was still held in high esteem.
Yeah, it definitely was. It was the late '70s, as Nancy mentioned. It was an interesting time. Economy had some issues. Moved from Michigan to California was a big transition for me. Nancy moved from New York to California, so we were adjusting to a different vibe, if you would. It was really interesting. We both enjoyed our experiences as interns, residents, as fellows. So we both enjoy learning, and there was an awful lot of learning to do. Medicine was evolving at that time, and the evolution has continued. I'd actually call it more of a revolution at this point, looking back. But it was still a priority on being within the ranks of the hierarchy, following the guidance of the people that had gone before us. It was a very regimented program. You had your rotations, electives. Your next few years were all planned out for you. So the next 5 years of my career is just march as I'm told to, and I think the same for Nance.
Yeah, being an intern, you basically did not have a life outside of just being in the hospital. Your luxury was if you could catch a full night's sleep. You know, we were on call sometimes literally every other night, and especially during a surgical rotation. I always remember the chief surgeon saying, "Yeah, I feel so sorry for you guys. You want to know why?" And we thought he'd say, "Oh, because you're not getting enough sleep, you're not getting a chance to eat." No, being on call every other night, you're missing out on 50% of the cases.
Oh, that's so classic. I feel like, despite the fact that I'm a couple, maybe one or two generations beyond that, I feel like I heard the same thing from my
You,
surgery attendings.
Absolutely. It was very, very regimented. We did this and it was much worse when we did it, so no complaining. But thankfully, it's much better for the residents these days. I think medicine has recognized that the idea of people training on zero sleep is not good for the
Well, there
patients,
was a
not good for
famous
the doctor.
case.
It was a famous case. It was in New York. I think her name was Libby Zion, if I'm not mistaken, a young lady who unfortunately and tragically died because the resident taking care of her was sleep deprived and made a mistake. And her parents were strong advocates for correcting the system, thankfully. And they passed legislation, which in New York limited the number of hours that interns and residents can work before they're given a break to rest and to sleep. And that's been adopted nationwide. So it takes time for medicine to evolve. It's a very slowly evolving profession. It takes too much time, as far as we're concerned, for advances to be made in our fields.
So I remember when the work hour restrictions went into place, at least where I was. I was in Tucson, Arizona, and I did my emergency medicine residency from 2009 to 2012, and it was in my senior year. So that would have been 2011 to 2012 that the incoming interns were the first class that were actually not going to be allowed to stay in the hospital for 24 hours, where they put in the like 12-hour shift restrictions, and so they would be on night shift or they'd be on day shift in the ICU. But my class, we still had the Q3 call with 30 hours in the hospital, one day off a week. So I remember those times, but yeah, I think it's so much better now that we do have those work hour restrictions because it is a frightening experience to be new in your training and to want to do your very best. I think all of us go into this field because we are motivated to do our very best for people that are in the hospital, that are sick, and help them to the best of our ability. And it's like drinking from a fire hose when you first show up on day one, as you were describing, and to have to navigate all of that and to not have had any sleep is just really inhumane and not safe for anybody.
Oh, we couldn't agree more. We could not agree more. And it's disappointing that your program, and it was sophisticated enough to recognize the times have changed. We've got to let these interns sleep. But no, we're not going to let the residents just 1 year ahead sleep. They're going to have to go through the system for another 2 or 3 years, or how many more years you're in training with the old system of being sleep deprived. So even though we see that there's a reason to improve, let's just improve for the incoming group, not for the ones who are already here.
Yeah, I don't know. I mean, I don't really know what the logic was. I don't know if it was just an old school mentality or if it was a staffing issue. I'm not really sure. I know they did get some additional funding and they were able to hire more residents in the upcoming class. Um, but yeah, I mean, there there's got to be I think a cultural shift too, which is hard to do. It's not just the rules and the laws that come into place, right? It's like the mentality of the people who are training those underneath of them and recognition of how we might do that in a better way.
Totally agree with you, Joy, that it is a mentality, and it was kind of a tradition back then that this is the way we did it. You have to go. It was a hazing, a definitely form of hazing.
And I might mention, Dr. Joy, that in my experience, because I did spend some time traveling, I went to different medical schools, hospitals during my training. I had quite a broad experience. I met professors of different ages, different backgrounds, and there definitely was a generational shift. So when I was going through training, the senior doctors who were in their 70s, basically very much old school mentality. We suffered, you're going to suffer. The next generation down, a little more liberal. We can improve things a bit. So the more advanced you become in years, the more rigid I think the thinking becomes. So it's a change and a challenge.
For sure, for sure. I'd like to hear a little bit about how the two of you decided that you wanted to go to medical school. Can you remember a first memory of when you thought you might want to become a doctor, whether that was in childhood or later on in university?
Sure. I loved animals, and I still love animals. And um, growing up in New York City with a mother who was highly allergic to cats and dogs, it was a bit of a frustration. And so I took it upon myself as a 5-year-old, 6-year-old to take care of all of the stray cats in our neighborhood. And so I would feed them outside the home. I would give them a little cardboard box in the winter with some blankets and take care of them. And one particular cat, her name was Goldie, and she really befriended me and she became my soulmate. And I recall very vividly that it was a cold winter day and starting to snow. And I went out to feed my favorite little Goldie. And by the way, my mother was asthmatic. And if I came in with cat fur, she would, go into an asthmatic attack. So I had to be very cautious. But took care of Goldie. And one day, Goldie decided to crawl out of the box and she's sitting on my lap. I'm petting her and she's making these loud purring sounds, getting louder and louder. And the next thing I know, I'm just baffled because there are blobs coming out of her backside, it looked like. Lo and behold, Goldie is giving birth to kittens on my lap. And I am watching with sheer amazement. She knows what she's doing, and I'm just watching. She's blobbing all these kittens out, making these incredible screeching sounds. And she's cleaning them off. And the next thing I know, she's twirling around, and there's an umbilical cord and a placenta. And I'm at this point, I can't just sit there by myself, and I have to go and tell my mother what's happening. And sure enough, um, that was my very first delivery, by the way, my assisted delivery. My mother was also shocked, and she let me bring Goldie inside the house, and we cleaned her up and the kittens. So I had my first, quote, veterinary experience, but also perhaps that put the seeds in my head for future career in OBGYN. I started reading, even at a young age of 6, words in textbooks about childbirth and words like, what does vagina spell? Is that a vagina? What is that? Anyway, I started to self-educate. So that was, I guess, my first foray into the world of reproductive medicine, but still wanting definitely only to be a veterinarian. Continuing, I knew that as I was getting older that, yeah, if you want to be a veterinarian, it means you have to go to college, you have to go to veterinary medical school. And I was growing up in New York City, and as a female, there was a prejudice against city dwellers and especially women going into veterinary medicine. I was fortunate, though, to go to the only public New York City high school that offered an agriculture program. And so I applied to that program because being an Aggie would have, number one, I loved agriculture. I loved the country. I loved farming. And that would give me a better background to go to veterinary school. But I'll never forget the interview I had with the director of this agriculture program. Number one, it was geared mainly for men. And so when I sat there and he was looking at me, he goes, "Gee, like you're this skinny little girl. Do you know anything about how are you going to handle the cows, or how about the horses?" And I said, "Well, my understanding is that even the guys can't pick up a horse or a cow by themselves, and there's such a thing as a hydraulic lift these days." And so then he kind of gave me a smirk and he goes, "Do you know how to drive a tractor?" I said, "No, not yet, but I understand that's one of the things you're going to teach during this course." And long story short, I was accepted one of two females into this Aggie program, New York City, John Down High School. They still have the agriculture program there. And so for 3 years, I learned everything there was about farming. I learned how to drive a tractor before I learned how to drive a car. I learned how to pour a concrete foundation. And one of the summer programs and requirements was to actually work on a farm. And that is where my mindset took a transition. I was assigned to a farm in upstate New York, which I was totally excited and happy about. I was going to take care of the animals. I was going to learn everything the farmer did. But what I didn't realize is that basically my program offered me up to be literally a slave, no pay at all, to a poor young farm couple who could not afford a farm hand, and that I was going to be their free labor for the summer. I was willing to work hard, and they had a young 3-year-old daughter that they had me babysit for, in addition to cleaning up the cow manure and whatever else they asked of me. But one day or one night, the little girl got into some old containers, and apparently there was kerosene, and swallowed it. It was a horrible emergency. And when they realized what happened, we all jumped into the family's truck, and we had to travel about 70 miles to the nearest doctor, the nearest country doc. Now, when the cow would have a problem, they would just get on the phone and the vet would be over in less than 5 minutes. And it was at that moment that I took another look at my future goals and said, "Gee, you love animals so much and you could always do good things for animals, but maybe consider being a country doc, because they really need to have doctors out in these rural areas, and there are none there." Fast forward the next summer, I did do some volunteer work in a veterinarian's office, and also discovered part of being a veterinarian, at least at that time, was when an owner would come in and say, "Gee, I don't want to spend $100 to fix this poor pooch's leg, just put him down." That was a requirement. And the vet looked at me and said, "If you're not going to do that, you shouldn't be a veterinarian, because they're going to ask you to do things like that." So I kind of put a couple of things together and said, "Gee, I'm going to be an advocate for animals and not do these killings, and do something good for people." And I shifted my mindset from veterinary medicine to human medicine, and applied to med schools after college. Got into, I think, 4 or 5 of them, and I still love animals and still am an advocate for all things to do with animals, but kind of that's where the transition occurred.
My choice for becoming a physician was strongly influenced by my father in an awkward way. I think I was 4 years old, and he was asking me, "What do you want to be when you grow up?" And I answered, "I want to be an alligator. They are so neat. That's such a neat animal. That's what I want to be." And he said, "No, no, you can't be an alligator. What do you want to be?" And I wasn't sure. And he made a comment, and it's partly because of our family background. It's of the Jewish faith in Europe at the time. And unfortunately, they were there during the time of the Holocaust. And my mom was in a concentration camp, Auschwitz, and my father was able to survive. And my mother survived, but many family members were lost. And one of the things that they brought to mind to the three kids, I had two brothers, and by the way, all three of us are physicians. And I think it was my father's influence again. Whatever field you go into, make sure it's a field that if you need to flee your home country for whatever reason, you have something that you can take with you, but it can't be anything physical, it has to be in your mind. Get an education, get a degree, find a profession where it's an international profession. So, in a way, it's a bit of a survivor syndrome hand me down that I got at a very early age, that medicine was an international field. I really do care about people and like helping people. That's attractive. It's intellectually stimulating. That's attractive. I've always liked the idea of being an adventurer, discoverer, explorer, and there's plenty to explore and learn in medicine. So it hit all the right measures of what I was interested in, anyhow. So it ends up that medicine was imprinted early on. But if I had a choice, and I did have a choice, one of the things I really enjoyed, I think I mentioned one of my undergraduate majors, was medieval English literature. What I really wanted to do, and I remember this about being 11 or 12 years old, is I wanted to go to Oxford as a Rhodes Scholar. I knew about Rhodes Scholarship back then. I was sort of on an academic bent all along. And I wanted to become a professor of medieval English literature. That's what I really wanted to do. So medicine was a second calling, but that would be my backup. Obviously, I'll go ahead and get the MD degree, but I also wanted to teach medieval English literature. Things changed when I was about 14. My mom, unfortunately, although she survived the Holocaust, did not survive cancer. She ended up with metastatic breast cancer at age 44. I thought I've got to go to medical school early and find a cure for cancer, otherwise, I'm going to lose my mom. So I accelerated my high school education, completed courses early, was accepted to universities at age 15 and went to three universities at one time to get all the courses for pre-med. Ended up getting accepted to medical school young. Started medical school when I was 19, but it was too late. My mom was already gone. So I remember vividly the importance of physicians in her care, how we looked up to them. They basically were the life and death difference for her and for others in that situation. So it's a tragedy, to say the least, but it also served as a very important lesson for me, the importance of having compassion, caring for people, caring for the patients. And I've never forgotten an essay I read just before I started medical school, and it was written by a professor from Harvard, Dr. Francis Wald Peabody. And it was an essay on the care of the patient. And the bottom line, which he said, and I've never forgotten this phrase, the secret in the care of the patient is caring for the patient. I've never forgotten that. And it makes all the world of a difference if you go into medicine, having patient care, compassion, empathy at the forefront. And that's what I encourage. As I mentioned, I do teach. I'm a volunteer, a clinical professor of medicine, University of California, San Diego, and I enjoy teaching medical students. That's what I consider my most important lesson to them, is the importance of having compassion, empathy, communicating with the patients at their level as an equal. And it's something I've never forgotten, and I'm happy to share with others.
Thank you for saying that, and I couldn't agree more. So it sounds like if you had to do it over again, you would probably make the same choice. Am I correct in assuming that?
Well, I would say that medicine has been terrific for me. I've enjoyed it. I really embrace the philosophy behind caring for people and the concept of always learning, always studying. I love that. Gastroenterology has evolved. What used to be a very procedure oriented field, and it still is to some degree, is also a new horizon looking at the gut microbiome and the microbes that are inside. And that is a fascinating new world. So, all things considered, yeah, I would still say with GI, but focus more on the gut microbiome and the science there. It's just fascinating.
Yes, looking back, I would still choose the path of going through medical school, and maybe I would have told myself, well, first of all, if I was doing it now, it wouldn't probably be as grueling in terms of that, the internship. And I probably would have been able to pursue some some more lifestyle balance than I had back then because, yeah, 4 years of your life, especially OBGYN, where you know for sure when you're on call at night at a city hospital, you're not going to get any rest at all. So I think actually I would probably be going through it and have a little bit more time for things that I was passionate about. How about for you, Dr. Joy? What about your thoughts on that? That's a great question.
My thoughts on whether I would do it over again?
Yes.
Well, sort of like G.I. Joe, I also have an interest in literature and writing, and I have a creative side to me that I feel like I had to put on pause for the time that I was going through my training. It's just so intense. There's not a lot of time for extra things. And I also was raising a family all through the last part of medical school and into my residency. However, I've been able to come back to some of those passions now. Number one, with this podcast. Number two, with the creative writing that I do, and hopefully can use that skill set to bring forward some of these ideas that we're discussing today. But in terms of would I do it over again, it's hard to answer that question because I cannot imagine my life and what I would be like, the kind of person that I would be if I had not gone through the experiences that shaped me, not just as a doctor, but as a human. I think that because my specialty was emergency medicine, of course, everyone in residency training, they rotate through the hospital no matter what specialty you are, even dermatologists, they do an intern year and you do hospital-based medicine. But for me, my career, most of it at least, was in the hospital dealing with life-threatening things. And as such, I had the honor to be a part of people's lives at their time of greatest need over and over again over many years. And I think that has deeply affected me. It has really given me so much perspective on the human experience. And I've learned through those experiences of the suffering of others. I've just been in awe of the strength of the people that I've taken care of and continuously inspired. And so it's hard for me to answer, would I do it over again? I think I would do it over again, but it's also hard for me to even separate in my mind the person that I would be today if I hadn't done it. So it's hard to answer the question. I'm not sure if that makes sense.
It does. I feel what you're saying personally as well, so I get it.
Dr. Joy, I think you being in emergency medicine gives you a different perspective than those of us who've been in the clinics where it's not as urgent. You have a little bit more time. So I have a great deal of respect for what you do and how challenging that is. And I really appreciate your description of the honor it is to take care of people, because that's the word I should have been using earlier. I consider it an absolute honor to care for people.
And I think what also stands out to me is the fact that people put their trust in us in these very intimate moments without even knowing us. I can think of so many different times where I'm meeting someone for the first time in crisis, and there's that instant trust and rapport that I don't take lightly. That's a huge responsibility that I carry to shelter that person, to to be ethical in how I conduct myself, to make sure that I am the best that I can be for that person's well-being. And there's not a lot of other professions where the public instantly gives their trust to someone who has literally, you have that person's life in your hands. And it's in part out of necessity in the emergency department. Somebody shows up and they really have no other choice. But at the same time, I think that it's remarkable that we are given that gift of that trust and that people do let us into their lives in those really difficult times. And I think that because of that, it's also really given me perspective on my own life, how fragile things are, how lucky we are to have the time that we have. So yeah, I don't think I could see myself in a different career or profession because It's become so intimately intertwined, the person that I am, not just the doctor person, but the mom that I am, the friend that I am. It's made me who I am.
So yes, I hear that it is woven into your identity at this stage of your life.
And what we're talking about now really it gets into the art of medicine, right? It's not just about the science. It's about the way that we interact with the people that put their trust in us.
Something I learned from another physician teacher many, many decades ago, making hospital rounds. He would always ask one question of the patient before he left. He says, "Is there anything else I can do for you to make you more comfortable while you're here in the hospital?" I thought, now that is an artful thing to say and a beautiful thing to say. And you can just see in the patient's eyes how that made all the difference in the world. Or touching their hand, the gift of touch. So there are so many forms of the art that can be taught, can be shared. And I found the students to be very receptive for that. They really appreciate being shared some of the insights that I've gathered and I've learned from others. And I love sharing that with others as well.
I can really relate to the things you're saying, and I think that the importance of touch cannot be underestimated. I know these days with technology and everything, to some extent, I feel like we're losing the art of physical exam because we have other things that take the place of it that might be better than our detection skills. But I can tell you that there were so many times working in the hospital where I had a patient that was semi-conscious or mostly unconscious, that, their, brain function at the time, because of the medical issues that they were dealing with, made it impossible for them to have a conversation. But there were times where I would just take their hand and squeeze it a little bit,
Mhm.
give them that reassurance, and then they would squeeze it back. And that's how I knew that they felt that presence there, that they knew they were being cared for. And I don't know if that's something that people remember, when they're in that state. A lot of times we have amnesia to those events and can't recall what took place, but I still believe that in that moment it made a difference.
Oh, it makes a world of difference. And I'm so glad you do that. And that's one of the things I share with patients. And I've also shared with others as well. Unfortunately, I lost my mother to metastatic breast cancer, but she was in coma before she died. And one of the things I was taught, and I believe it, is that people, even when they're in coma, can hear. Hearing is the last thing that goes. And she actually came out of the coma for a brief period of time before she went and died. And she did describe what was going on and what people were saying to her before she finally passed. So there is, it's never too late. If they're still with us, we can say the things we want to share with the loved ones, even if they're on their way out. In fact, one can even say, even after they have passed, there may be an ongoing, lingering consciousness that may take some time before it really has transitioned to the other side. So that empathy and compassion, that art, is received. So you did a beautiful thing by holding their hand and sharing your compassion for them.
And also, patients do appreciate, especially if a patient's going to face surgery. And I always share with my patients just before a surgery, number one, to introduce them to the anesthesiologist, to let them know that we're here for them, that we'll be saying our own positive affirmations throughout the surgery and holding their hand. There's nothing worse than being wheeled into a sterile operating room and not knowing anyone, and the doctor who's going to take care of you isn't even present at the moment. So I really stress that to young physicians who I am teaching, and also to empower patients who are facing surgery and let them know that this is something they can ask for. I want to know who my anesthesiologist. I want my surgeon to be there with me, not come in after I'm already put under the anesthesia. It makes a difference.
I was just that Nancy also make another comment about how she introduces herself to patients. It's an important point about being dressed, undressed. Nancy will bring that up. I think it's an important one.
Well, often new patients would be taken into a doctor's office, not mine, but another doctor's office, and they were already told to disrobe and put on a paper gown, and you're sitting there, as happened to me. I'm sitting there, shivering and half naked, and a stranger comes in and he or she is fully clothed, and you're already kind of on an unequal basis. So in my own practice, I made sure to tell my medical assistants that I will always meet my patients on a equal basis. They'll be dressed and I'll be dressed, and we'll have a face-to-face conversation and get to know each other on a personal basis before getting to know each other on I'm the doctor, you're the patient, I'm dressed, you're not dressed, you're vulnerable, I'm not. So I think that we really should keep the balance of being person to person, human to human. And the secret really to caring for the patient is in caring for the patient.
I think that that's so wonderful, Dr. Nancy, that you do that. And I can relate to that as a woman having to go into OBGYN for my routine checkups as well. That I think it's not intentional, right? It's for efficiency's sake that they're trying to save the time of going in and then having to step out, waiting for the person to undress and then going back in again. But it really does make you feel intimidated when you're meeting someone for the first time and you're not fully clothed. I'm so glad that for the people that you take care of, that that's how you conduct your visits. I would appreciate it if that was the case and I were your patient.
Absolutely.
Dr. Nancy and G.I. Joe's commitment to the art of medicine, the human to human element, the part that involves compassion and empathy, has not dwindled. In fact, it has only grown stronger through the decades. But alongside this constant and deepening shared core value, they have also witnessed our field change dramatically over the course of their careers. The pace of medical research and discovery has accelerated, and a new approach will be required to adapt.
Dr. Joy, it's a challenge, and there are many challenges in medicine, but the biggest challenge is to keep up with the advances. There have been reports in the medical literature that on average, doctors are about 17 years behind. That was what was reported over 20 years ago. I'm convinced that we are further behind than ever. The number of research papers published every year now exceeds 2 million research publications every single year. If you knew everything there was to know about medicine on January 1, by the time December 31st ran around, you would know about 2% of what there is to know about medicine. It's changing that quickly. And it's impossible for the docs to keep up. Now, there are services that try to summarize the literature, and we all read the newspapers. Hopefully, there's a big breakthrough. It'll make the New York Times or Wall Street Journal or be on the evening news. But there are so many advances in medicine, and we see it all the time where the docs are simply not aware of advances, and they're treating patients with what was the standard of care 5, 10, 15, 20 years ago. I don't ever want to do that. So I'm always trying to keep up, but I know it's a losing battle. I think that's the biggest challenge, is keeping up with the advances in medicine.
So, from my perspective, I see another challenge, and that is many physicians are now having to listen to, quote, guidelines that may not be in the patient's best interest. So, for example, if I wanted to make a recommendation for a patient and I feel that is my number one choice, having to first say, well, we can't do this right now. We have to, quote, submit it to your insurance company and get prior approval, and then that takes forever and it may delay the care. And I think there's some interference in how to practice the best medicine that we feel we would like to deliver to our patients. And that interference often is the third party, and who are not physicians, they're administrators in the insurance industry.
Dr. Nancy, can you think of a particular example that you find comes up frequently in your practice with respect to what you just were discussing?
Well, I'll go back even a number of years ago where submitted some claim for a patient, and the payment for the patient was denied, and the crazy rationale was, well, she has a pre-existing condition called, quote, menopause. Pretty blatant, huh?
Oh my goodness. That is unreal. I can't believe that that would be even listed as a pre-existing condition. That's like saying your pre-existing condition is being an alive human being.
Yes, correct.
Many of us remember the days when insurance companies could use a person's medical history prior to when coverage started, termed pre-existing conditions, to deny coverage for needed medical care. Thankfully, the Affordable Care Act put an end to this unfair practice in 2010, and now health insurance companies cannot refuse coverage or charge more because of a pre-existing condition. Yet insurance companies still regulate what will and won't be covered through the use of guidelines.
Well, medicine is so primitive when it deals with the insurance companies. We have clinical guidelines that we're supposed to follow, but the clinical guidelines are outdated. By the time they're published, medicine has advanced. So you'll see clinical guidelines where you're supposed to adhere to them, but they're incorrect. And to get the insurance companies to agree to that, you have to go through what's called a peer to peer review. You submit the claim for a service, which is appropriate. It gets denied because it doesn't meet the guidelines. And you have to spend time getting on the phone to talk to a colleague. And sometimes it takes a week or two to schedule the call to explain to them, your guideline's a bit outdated, don't you think? Oh, we're going to correct that eventually. But in the meanwhile, it's just eating up so much professional time, which the docs are not compensated for. Their office practices are not compensated for. So many physicians are spending about 30% of their office overhead dealing with insurance claims processing. And it gets worse. If you go in to see a physician and they're on the computer typing away as you're trying to tell them what your concerns are, they're typing in information that the insurance company requires to be input into the computer before they will process the claim. So I've seen physicians where they're staring at the computer for 5 or 10 minutes and then they glance up and look at you. And then they go back to the laptop, putting more information in. So it's really an awkward situation. What used to be a conversation with a professional is now you have a 15-minute office visit. 5 minutes are taken up with the input of information to the laptop, and it's just a very dysfunctional system.
I think another thing that patients don't realize as well, with respect to what you were just saying, is that the stakes of not putting the information in correctly are very high for the docs. It's not just about quality metric reporting or, getting good scores on your quality metrics or even necessarily getting paid. It's also the audit process, because if you aren't documenting things the way that the insurance companies require, and then 6 months later they turn around and want to do an audit on your charts, and then they pull your charts and then they say, oh, well, you didn't document this thing here or that thing there, you didn't do this perfectly, you're at risk for having them take back all that money that you got paid, and it could take you out, especially if you're in private practice. So it's not just about checking boxes for something that's minor. I mean, people's livelihoods potentially are at risk if the paperwork is not done correctly, which is incredibly frustrating and frightening, especially for me now that I own my own private practice. It's something that we have to pay attention to as much as we don't want to, because we do want to be focused on the patient. That's the thing that we care about, is, to be there for our patients, but we have to put so much attention and focus on this other piece as well.
Absolutely. And it's being dictated by people who are not really healthcare professionals. They may be healthcare administrators, they may be insurance administrators. A lot of the information that is required is of no real value to the physician or to the patient. It's just for their own purposes. And again, they don't provide enough time for people to put that information in. If you have a 15-minute office visit, it's hard pressed to take care of the patient, much less take care of the paperwork and administrative responsibilities.
I totally agree. And so what we end up doing in my practice is we schedule longer appointments and we just take the hit financially, because we don't want to sacrifice that face-to-face time. And so we don't have any 15-minute appointments. Our appointments are 20 minutes or they're 40 minutes. Sometimes we even book hour-long appointments depending on what we need to accomplish, and we just live with whatever reimbursement we get for that. It is what it is.
It's always a fine balance between giving the quality that you want to give to your patient and then feeling like sometimes the doctor is the monkey in the middle, so to speak. Another concern I would have is, and way back when I stopped being part of these HMO programs because I was required to be referring patients to sometimes physicians that I personally would not want to go to as a specialist. So I wanted to have the liberty of telling my patients, well, these are the doctors I think would be the best for you. So when I had contradiction in my own sense of ethics, I dropped out of being part of these HMO programs.
I think that's a really good point, and I also think that a lot of people may not fully understand the difference between HMO and PPO and all of these terms that we use. But essentially, HMO is an insurance plan that really embraces the concept of managed care and a physician network. So it essentially makes your primary care doctor the gatekeeper for everything that you do within the health system has to be signed off by your primary care. And also, it limits the providers that you can see for whatever health condition you're dealing with to the doctors that are in network and contracted with that HMO. The HMO plans, just for those who may not be familiar, they really just put a lot more obstacles in the way that have to be worked through in order to navigate the system to the care that you need. And that can be very frustrating for both the individual who needs the care as well as the doctor who's trying to be the advocate for the patient.
That's correct, Dr. Joy. And I also comment HMOs are a very interesting concept. And for public health, for population based care, there is a logic, there is a rationale to try to keep the healthcare costs down and provide a level of base care. But I think what the consumers don't recognize is that HMOs are really focused on what's called population based medicine. This is what's best for the average person. And therefore, that's what's best for you. At least our philosophy is there is no such thing as an average patient. Everybody is a unique individual. And if you tailor the care that they deserve to them as a unique individual, it may be very different than what would be recommended for population based care. So, to give you an example, I'm a gastroenterologist. We talk about colon cancer screening and what's the best approach. There are all sorts of options. And although, as a gastroenterologist, colonoscopy is something I should be very fond of, I'm not as big an advocate as many others might be. I think there are other less invasive, less expensive ways to be screened for colon cancer. So there are stool tests for occult blood, the FIT test. There are the Cologuard, which is a multi-target DNA test. There's a blood test that's available now. There's virtual colonoscopy. There are a whole variety of choices. And if you can dictate by the insurance company, HMO says this is what you're going to do and this is your only option, that's what you have to do. But that's population based care. If you give people the options, these are the various selections you might make, and this is what's best for you, it might be a very different recommendation than a population based.
Totally. I could not agree more with that statement. And I think that is actually a really good analogy of what is happening in healthcare today, which is that, as you described earlier, we are just getting inundated with so much new research, so much new understanding that's coming to bear, and it cannot possibly be consumed by every single doctor that's out there because there's just too much of it. And at the same time, that technology and that understanding and that knowledge is helping us to become more individualized in our approach. I think that, if I look back on my career, which is not as long as yours has been, at the beginning of my career, it was very in vogue, these kind of population-based approaches to healthcare. And I feel that there is a major shift happening, that we are realizing that we cannot take a one-size-fits-all approach. And the standard of care for one person may not be the same as the standard of care for someone else. And the more that we learn about individual genetics and, as you mentioned, the microbiome and all other sorts of factors that are very specific to the individual that do not lend themselves to broad generalizations and guidelines, I think that there is an inherent conflict that is emerging between population-based health and individualized health. And that is something that we are going to have to reconcile over the next 10 to 20 years, because we are going to get more and more granular in the types of diagnostics that we can perform, in the way that we can figure out, what medication would work specifically best for you based on how your body metabolizes this medication. We're seeing more and more examples of that coming into kind of our daily practice. And yet the whole infrastructure of the health system is set up in this population health management way that is quickly becoming something of the past.
Dr. Joy, I could not agree with you more. And we're moving into a new era, what we describe as precision medicine, being proactive, personalized, having it participatory, having the patients involved as well. And that is where the advances in medicine will come, much as like you're describing. Even prescription medications, they come in 2 or 3 different doses. Wait a minute. There are so many different variations in our body composition, our weight, our size, our gender. We should be much more specific. And there are advances in the technology from pharmacogenomics to very specific DNA genomic identification of what people are at risk for, what should be done. If you're looking at precision medicine, it is a completely different perspective and approach than the population-based medicine approach we're taking today. And population-based medicine served the country relatively well, but it's not serving the individual patients very well. And there is so much more we can offer to patients as far as precision care, where you're avoiding unnecessary drugs, avoiding side effects, avoiding procedures, avoiding additional imaging studies, and a more accurate diagnosis. What many people don't realize is there are still mistakes made in medicine, not because the doctor wants to make the mistake, but we're restricted by the insurance companies and by what we're allowed to advise. We're basically hindered from practicing precision medicine. It's still population based. What's best for the average person is good for you, and that's not true. And we know it. So we're having an uphill battle changing and challenging the clinical guidelines from the insurance companies, which are all population based. So precision medicine is where we should be going, and it'd be great to get there without so much resistance from the powers that be.
I've really appreciated all of the insights that you have and the wisdom that you've been willing to share. And I know that the people that are listening are really going to appreciate what you have to say and what you lend to this conversation.
Thank you for listening to Your Doctor Wants to Quit. I'm Dr. Joy, a board-certified emergency physician, and I created this podcast because I'm on a quest to fix healthcare in America through conversation. If you liked what you heard today, please follow this podcast or find me on Instagram at drjoymd. That's DOCTOR Joy MD.